Hey guys, so today we're going to talk about trachs, tracheostomies, suctioning. This will not be on the midterm. Let's talk about some key terms that you're going to hear throughout this lecture. So the first one is tracheostomy, and tracheostomy is actually the opening in the neck. So how I like to remember it is a stoma is where the trach goes through. It's the opening in the neck. And you have stome in the key phrase here. So tracheostomy, stoma, tracheostomy, it's the actual opening. And then you have tracheotomy. And this is the procedure of uh, establishing access through the trachea via an incision through the neck. So the tracheostomy is the procedure. So it's important to know the difference between the two. So the tracheotomy is going to establish and access the trachea via an incision through the neck. It's important to understand the keywords, the phrases, and how this works because we're RTs. We own that airway. It is our responsibility to make sure that our patients always have a patent airway. So in this lecture, we will go over the procedure of establishing a tracheotomy at both the bedside and in the OR. Okay, like I said on the last slide, this procedure can be done surgically in the OR, so OR is the operating room, or at the bedside. So remember, the procedure itself is called tracheotomy. And establishing the opening is the tracheostomy. Okay, so the incision should be between the second and third tracheal ring. So when it's done in the OR, so this is our OR, and this is bedside, and that is called a percutaneous trach. As you can see, both of these are done in different ways depending on if it's the operating room or at the bedside. So as you can see with the OR, the opening to the neck through the skin and the muscle and all the tissue is a lot larger than at the bedside. They actually pull open the tissues, cut a hole with a scalpel across the trachea between those second and third rings, and then place the trach itself. So this is the trach here that the physician is holding, and that's the cuff, and we'll go over trach parts later in the lecture. So they place that inside, and then these blue lines, what you're seeing here, or strings, are stitches. So when they're in the OR, they're going to place that trach, and they're going to stitch it to the skin out here on the side so that the tissue will close around it and heal. And then after 5 to 7 days, the stitches are removed. So like everything else, hospitals are going to have different procedures. I can speak for St. Anthony's. Our procedure was after 7 days after having a trach placed in the OR, the RT was to get orders from the physician, the critical care physician, or the trauma surgeon who placed this trach, and we would remove the sutures. Okay, for bedside trachs, and we're going to watch a video in a second. The bedside trach, this is a percutaneous trach, and this is a dilator. So the bottom part of this blue, it's called a blue rhino, this one is, they are dilating that hole, so they're going to cut a little hole through the skin using the anatomy, and you can see the lines that they use to mark this patient. And as they put the dilator through, it's going to stretch that hole open so that it dilates it and gets it big enough for the trach itself. So after, you can see up here, you've got this lead. It's a little white, like a placeholder. So that goes in. Once they get to the size that they need, depending on the size of the trach tube that they are using, and we'll go over sizes, then that placeholder stays in there, that little white part stays in. They pull this blue dilator out and they place the trach itself in. And then they secure it with trach ties instead of stitches. Personally, my personal opinion, if you guys are ever my RT and I have to be trached for whatever reason, please make them do a percutaneous trach. I believe that they heal a lot better. The scars after having a trach with a percutaneous trach is going to be less than those that are placed in the OR. So this is a pretty cool video of a percutaneous trach, a bedside trach. Even just from the picture here, you can see the vent. They have a bronch that they're going to place the trach. This is the RT over here. I can't watch videos with you on this platform, so I'm going to post the link for this video. If you watch it and you email me 2 questions, I will give you 5 added bonus points for today. It can be any questions that you want about trachs, about what's going on during the video, what's the RT role, what was that equipment I saw, all of that. So 5 extra points if you watch the video and then send me a couple questions. So as we saw on the previous slide, OR trachs or bedside trachs, which are percutaneous trachs. So let's talk about some contraindications. So absolute. Would be need for an emergent airway. So what that means is, you'll see in the video that we're going to watch next, that if we're at the patient's bedside in the room for them and they start crashing, or maybe you're called to the emergency department and they have a gunshot wound to the face and they need a trach and they need it now, or we need to establish an airway, it's an emergent situation and for whatever reason we can't intubate, we are going to take them straight to the OR, because finding the anatomy and making sure that you are absolutely in the right spot for this trach, you're going to want to have a more safe environment where if something happens and the patient starts to crash, you're already in the OR and you have more supplies and resources that you need. Okay, so let's switch it up. So relative would be less than 12 years old. If they have poor landmarks. So some patients that may have poor landmarks would be your severely obese patients. If they're unable to palpate those tracheal rings and the cricoid cartilage and the landmarks that they use to mark, like you saw in that picture, if they can't feel them and they can't see them, they might want to err on the side of caution and take them to the OR. If they are already on the mechanical ventilator and they have a PEEP greater than 15 centimeters of water pressure. So I know we haven't gotten to PEEP, EPAP, and CPAP yet, but PEEP, so for those of you who are not very familiar with mechanical ventilation, a PEEP of 15, that's a high setting of PEEP. That means we're giving them a lot of extra pressure to help stint their lungs open. And it's going to help oxygenate better. So high PEEPs, they're if they're having a hard time on the ventilator and they're requiring high settings, it's going to be safer for the anesthesiologist to put them on their vent and have better control in case, God forbid, say they were doing this and they accidentally nicked that ET tube while they were trying to place the trach, and we've had to splint their airways open that much with that much pressure, and then something happens to the ET tube and their airway is compromised, we're just losing what we did. All that le- all that is leaking out, and so it's safer to go to the OR. If they have an infection, a burn, a growth over the tracheal site, so like a tumor, so then we're going to want to manage that. That kind of goes hand in hand with landmarks. And then if they have had clotting issues, so we're going to look at the coagulopathy. If they have bleeding issues, or the doc's going to look at all the medications that they're on. If they're on a high dose of heparin and they came in for a PE or some sort of thrombosis, and we know that if they're going to be a bleeder, it might just be safer to have them in the OR. That way, if they need blood, they can get it to the OR and it's not going to become a worse situation. So let's talk about tracheostomy indications. So you know me, know your indications. Okay, so the first one would be upper airway obstruction. So this is something that causes the nasal passages to be bypassed. Um, so, or the mouth has an abnormality for whatever reason. It could be a birth defect, an anatomical defect that develops later in life, or the result of an accident after the trauma. Anything that is going to obstruct the upper airway that isn't able to be fixed or removed in a timely manner so that the patient can breathe. The next indication is upper airway trauma. So upper airway trauma. So this could be a car accident. Say you have someone who hits the steering wheel with their nose and just does massive damage to that upper airway. Or you have someone who's doing some sort of weird internet challenge and they totally mess up their nasal cavity and they need surgery and they know that it's going to be a long time, they're going to give them a trach. Or you have a patient who tries to commit suicide by shooting themselves via a gun in the mouth. It does happen. You're going to see it. I want to prepare you guys a little bit for it. It can be something that changes you as an RT. It may be hard to see the first time you see it. I have had patients who have tried to commit suicide who put a gun in their mouth and they shot themselves, and they're unsuccessful in their attempts in what they wanted to do. We were successful as a medical team, and they still had their life. But you may see upper airways that are totally just gone, or their jaw is hanging down. If with those patients, they will be trached right away, and is the emergent situation. They're going to come in via ambulance. The whole team is going to be there, and they're going to be taken right to the OR. Okay, and we will talk more about that in emergency care. So poor airway protection. So as time goes on, this can be your older patients who just, they're getting older. They do swallow evaluations, and this might be an indication that they are getting lots of infections or pneumonias because they're slowly aspirating. So they'll do a swallow eval, and then you determine they're unable to protect their own airway. At night, if they go apneic because those tissues aren't as elastic as they were when they were younger, and it just obstructs that airway, and they can't keep a patent airway, they may be a candidate for a long-term trach. Okay, and then long-term mechanical ventilation. So I want you to take a minute and think why. Why would long-term mechanical ventilation require trach? Okay, so some benefits of having a trach if a patient's going to be on a mechanical ventilator for a long time. Well, we're going to eliminate vocal cord injury. If a patient has an endotracheal tube and you can visualize it, and it goes through their mouth, down in between the vocal cords, and then it sits above the 2 to 5 centimeters above the carina. In your suctioning, you have to suction because they lose this ability to cough and get their mucus up in your suctioning, or you're moving the ET tube, or they're just really mobile and they don't want to be intubated. And that tube is constantly on the vocal cords, we're going to cause damage. A trach is going to go below the glottis. So it's going to go below the vocal cords. It's going to increase patient comfort on the vent. They're going to be able to talk-ish. They're going to be able to mouth words to you. You can put passive mirrors in line, which is a speaking valve, and we'll go over those in line with the vent so that they can try and talk on the vent. You guys are going to get really good at reading lips. It's really actually a funny story. My best friend and I were having a family game night, and we played, I don't remember what it's called, but it's you put headphones on and then you try to read your partner's lips and to get points and what they're saying. Well, everyone was doing it and they would say like the funniest things. And then we were a team and we were killing it. We got it like the first or second try every time. Well, we're RTs and we work with trach patients, so we really learned how to read lips really well. So you guys will learn how to read lips. We can reduce sedation with patients that have a trach because they're more likely to be calm on the vent and not wanting to pull that tube out. It's easier to remove secretions. We don't have to go down as far with the suction catheter. It decreases that work of breathing because if a patient is anxious and uncomfortable, and then we're adding extra dead space, because if you look at a trach compared to an ET tube, the trach is just in the trachea. The endotracheal tube, it has to travel down farther to get to the lungs. There can be more resistance. And then the last one is a shorter wean time. So when we say weaning off the vent, we mean we're trying to get them off. Okay, so on the next slide, I will write these down for you guys. So we're going to do some takeaways. So some takeaways from indications, the indication slide. So benefits. With long-term vent. So remember, we have decreased vocal cord injury, increased patient comfort, decreased sedation, it's easier to remove secretions, we decrease their work of breathing, and we have a shorter weaning time. All right, so choosing the trach itself. So choosing the trach, choosing the trach tube is going to depend on the patient's age, their height, their weight, and their airway anatomy. So the airway anatomy, not everyone's the same. And when emergency care, we go over airways and intubations, and we look at their length of their neck, because that's going to determine how long their trachea is. Are they obese? If they're obese, we may need an extra long trach. So, okay. So let's say we have, this is the basic shape of a trach. If we have a patient who has a long neck, we might need a shorter tube that looks like this. So it's longer on the inside than the outside. If you have a patient who's really obese or has a really large jaw and it can get kind of trapped, you may need a tube that looks like this. I will be showing pictures, and we can go over on Zoom different types of trachs. So there's all different shapes. So deciding when it's the appropriate time to have that talk with the physician and the family about when should we trach a patient? How soon should we trach a patient? This is a big decision. This is a huge decision. Some people wouldn't want a trach. Families ultimately may have the choice of saying, I know he wouldn't want a trach. I just think we shouldn't trach him. You're going to come into issues with families like that throughout your career. You may have one family member who's fighting and saying, Dad wouldn't want a trach. And then his mom comes back and says, I know my son wouldn't want a trach. Or you have a patient, this is another hard spot, where one family member says, well, my mom wouldn't want to be on the ventilator with a trach, so I think we should withdraw care. And then you have another family member who says, absolutely not. We're going to keep her on the vent and do whatever we can, because I want her to be alive and she needs to be alive. So just kind of start thinking that it's a possibility and it might happen. And it's not our place to judge a family for their decisions on what to do. Okay, I will get off my soapbox. So, when is it appropriate to talk about trachs and putting one in a patient? So, this is a little flow chart. This is in Egan's, I believe. So, the onset of respiratory failure. So, this is step one. So, this is going on the vent. So, once they go on the vent, day 1 to day 3, we're looking at why are they on the vent? Are they on the vent because they were in a car accident and they just needed one surgery and sedation, and that's why they're there. They've had this surgery. Let's try and wean them. Did they go on the vent because they were too drunk to breathe, which is a thing, and they just need to get that alcohol? We just had to place that airway for them, let the alcohol get out of the system, and they're not going to be on it very long. Or are they a really bad asthmatic and we just couldn't avoid putting them on the vent, and this is not very good and we can't get them off the vent? Or are they an older patient who has lots of comorbidities? Maybe they became septic and they're really, really, really sick in the ICU. So we are going to look between day 1 and day 3 how long we think they're going to be intubated. So if we're like, yeah, he'll be off within the next couple days. I just want to keep him intubated with an ET tube because he's going to go back to surgery in 2 days. And instead of doing more damage to the airway and possibly causing trauma or losing the airway, we're just going to keep him intubated. If we know it's going to be less than 7 to 10 days, okay, it's all right. Let's reevaluate this in a few days. If we know that maybe this is that patient that came in that had the gunshot to the face, and we know that we have lots of plastic surgeries left, and we need to keep that trach because his upper airway's toast. If it's going to be greater than 21 days at day 1 or day 3, we'll go ahead and consider a tracheotomy. So let's say it's day 3, and we totally thought that Mr. Crazy Kid who did something stupid because he's young and dumb, we thought we were going to get him off. And extubation is probably not going to happen. So it's been 7 to 10 days. It's probably not going to happen. And he's bucking the vent. He's not doing good. We're finding there's more comorbidities. Maybe his blood pressure's dropped, so we have to fix all these other things. Then we would consider a tracheotomy. Now we're at day 7. Is extubation possible within the next 5 to 7 days? Yeah, it's okay. So we're at the end. We have this severe asthmatic, and we didn't want to put her on the vent. She's been on it a week, but you know what? She's been on different modes of ventilation, and so she's weaning, and we think we're going to be able to take out that tube. So we're going to continue intubation. If we have that severe asthmatic and we're like, we haven't been able to adjust any ventilator settings. I thought this would be better. The albuterol is not working. She's having a hard time on the vent. She's developing other comorbidities now. Then we consider a trach. So that was a lot of information. So what I want you to know is we are going to constantly reevaluate every few days. We're going to look at the patient physically, see how they're doing. We are going to look at ventilator settings. We are going to look at, is there other things going on with the patient? Are they developing more comorbidities? Are they getting sicker or are they getting better? We're going to look at them physically. Is their upper airway intact? Is there a possibility that we can be able to leave an ET tube or do a nasal tube, depending on what's going on with the patient? So now we are going to talk about trach features, what they are for. So I need you to be able to label. Be able to label this. So let's start with the flange. So this is the flange here. And it prevents the trach from slipping into the airway and provides a place on the neck where we can secure the trach itself. On the flange, you will see the outer diameter of the trach tube, and the inner diameter, so you know what size the trach is. It'll also have information about the brand and the size. So for example, say they have a 6 Shiley, then it's going to say 6 Shiley, and then underneath it'll have the inner diameter and outer diameter. So these are trach ties or strings, and that they go through the little holes on the flange, and then they wrap around the neck, securing it in place. The next part we have is the outer cannula. So the outer cannula is the primary structure attached to the flange, and the cuff is attached there as well. So you have the cuff here, and what the cuff does is it secures it in place in the trachea when it is inflated. When it's inflated, that's when we can provide mechanical ventilation. If you have a trach tube that does not have a cuff, you're not going to be able to put that adult patient on the vent, because all that air and the volumes we're trying to deliver is going to escape around the trach. With it inflated, it's going to allow for those volumes to stay in the lungs and then come out of the trach to the circuit. So circuit in, volume stay in the lungs, expiration goes back to the other expiratory limb of the circuit. So if you follow this little line from the cuff, you have the pilot balloon. So the pilot balloon is what allows us to inflate and deflate the cuff. It has a one-way valve that allows air in, but seals up after you remove that slip tip syringe so that it can hold the pressure. If you have an accident and the pilot balloon is torn off, that cuff will not hold any air. So then it'll cause leaks, and that tube needs to be replaced, or you can have a pilot balloon repair kit. Okay, so let's talk about the hollow inner cannula. So the outer cannula is attached to the flange. The inner cannula goes inside the outer cannula, and it has a 15 millimeter adapter. So you might ask, why 15 millimeters? So your standard, everything standard is 15 millimeters. Your bag. So if we needed to take the patient off of the vent, that bag is 15 millimeters. If you have a vent circuit and you attach it there, it's 15 millimeters. So all trachs are going to have a 15 millimeter adapter. So what the inner cannula does is it allows us to help prevent obstruction. Or if there is an obstruction, we can remove this piece here. So inner cannulas can be disposable or non-disposable. So if, say, we had a big, huge mucus plug and it gets stuck somewhere in the inner cannula and it's just nasty and you can't suction it out, you can remove the inner cannula and either replace it with a new disposable cannula, or if it's a non-disposable, you can remove it, clean it, put it back into the trach, and establish that patent airway again. So our last little guy here is the obturator. And what the obturator does is it helps with the insertion of the trach. So it goes in here and you can tell it has a rounded tip. So if you were to put a trach in and you didn't use the obturator, the end of the trach here has sharp edges. Once you feel them in person, they're pretty sharp, so that can cause airway trauma. The rounded tip allows for a smooth insertion. So, should we throw it away after the initial insertion? No, you should not throw this away. It should be placed in a biohazard bag and either taped to the vent or taped to the head of the bed or by the ambu bag, because if in the event of emergency that trach comes out, you're going to want to have that obturator to reinsert it and put it back into the trachea. So I'm going to get on a little soapbox here. When you go on a transport with a patient who has a trach, you need to make sure that you have the obturator, a trach one size bigger, or excuse me, the same size or one size smaller. You need to be able to have suction, and you need to bring a bag with you. Anyone who has a trach you need to make sure that they have an ambu bag or a bag in the room in case the trach is lost or something happens. And not only just the bag to be able to be placed on the adapter, the 15 millimeter adapter here, but you need to make sure that trach or that bag has a mask. So things that a patient should have in their room if they have a trach is a bag, an ambu bag with a mask, a trach the same size, and a trach the smaller size. They should always have suction in their room, and the obturator must be either taped near the head of the bed by the bag or taped to the ventilator. Somewhere where it's easy for any provider, a doctor or an RT or a nurse can grab it for you. Nurses should not be putting trachs back in. Every hospital is going to have a different policy on who's allowed to reinsert the trach. But no, you should always have the obturator available. You should not throw it away. So now we're going to talk about different kinds of trachs. So this is a Jackson trach. It's not seen as often. It is metal, and it is usually placed by ENT, which is your ears, nose, and throat doctors. This is also known as the silver Hollinger trach. So clearly it's non-disposable. So you have a picture, oops, here. This is the obturator with the rounded edge end. This is the outer cannula, the flange, and then you have the inner cannula that is not disposable. Oftentimes, patients who have, even if it's not the silver metal trach, the Jackson trach, or if they have non-disposable inner cannulas, they're going to have more than one. That way, if you take this out and clean it, you can put one in before you clean the other one. So these are non-disposable. You can see it's cuffless. So if this patient, for some reason, say they went to the hospital and because they were really sick and they ended up needing to be ventilated on mechanical ventilation, you would need to switch the trach to one that has a cuff. It is made of sterling silver, and these are going to be your long-term patients. They're easy to clean and they're durable. It's patient preference. People who have these really like them. So when we introduce an endotracheal tube or a trach into the patient's airway, we are putting them at risk for side effects, whether it be airway trauma or infections or increased production of secretions. So we need to be aware of these side effects and signs and symptoms so that we can help aid with the healing process of those and prevent them from becoming worse. So laryngeal lesions, This is going to be with the endotracheal tube. So the most common injuries to the larynx. So glottic edema. So 24 hours after extubation, swelling can worsen. So we're looking at the first 24 hours. So this is what we've talked about when we talk about racemic epi and subglottic edema. So we're going to check the patients for signs of this edema. So some signs of glottic edema would be stridor and hoarseness. And stridor is the big one. And this is why we use that cool mist aerosol, because with glottic edema, the vasculature in the glottis is dilated. And when it's dilated and edematous, that vasculature is letting some fluids leak out, which is causing the swelling. And racemic epi is going to cause those vessels to constrict. So it's going to hold in that fluid that's not going to let them out of the vasculature. Okay, hoarseness occurs most of the time in extubated patients, but it usually resolves quickly. So if you go on YouTube and watch videos of patients that have been extubated, I love, that's one of my favorite parts of being an RT is extubating patients and then hearing them talk. I love it. And you encourage your patient to talk because you want to hear if there's any vocal cord damage. You want to hear, and it also shows you how much swelling they have. So if you go on and you can hear people talk, it's normal to be hoarse at first. But when they become more hoarse and then they develop stridor, stridor is a more serious symptom. So again, treatment for this will be cool mist, racemic epi, and steroids. And the steroids would be intravenous. They wouldn't be inhaled. Okay, so vocal cord inflammation is another injury that could be caused from an ET tube, and then vocal cord polyps or granulomas. So these develop slowly, and it can take weeks or months to form. So that's why if we know a patient's going to be intubated for a long time, we would rather switch them to a trach. That way we can avoid these vocal cord side effects and injuries. But some symptoms are difficulty swallowing. So swallowing issues. After swallowing issues, we have hoarseness and stridor as well. So these apply here as well. If it's, excuse me, if they're persistent or they don't resolve on their own or they're very large, or if they're severe, there's a lot of them and they're occluding their airway or obstructing their airway, it might require surgery to remove them. So a less common trauma to the vocal cords would be paralysis or stenosis, and this is severe, and it may indicate a trach permanently. So it's severe, may require trach. And that's another reason that once we extubate a patient, we are going to ask them to say something or ask them their name or how do you feel or tell me hello. And this is something that we're going to go over this again and again and again through the program. I want you to know this information, sign and symptoms. So take away, know what the endotracheal tube trauma is, know the signs and symptoms, and how you would treat it. Okay, tracheal lesions. This is going to be what is caused by a trach itself. So granulomas are little growths. Tracheal malacia. So the two big ones here that you definitely need to know about are tracheal malacia and tracheal stenosis. So those are the two biggest and the most common. So granulomas are growths. So tracheal malacia is softening of rings. And if the rings in the trachea become soft, it's not going to work properly to act like a stent to keep that airway nice and open and patent. It's going to cause that trach to collapse. And then it's going to cause obstruction. Tracheal stenosis causes narrowing of the trachea, and scarring. It is possible to have a tracheoesophageal fistula. What are some symptoms you might see with tracheoesophageal fistula? So you might see abdominal distension. If your patient's on the vent and we're giving them lots of pressure, that air is going to go through that fistula from the trachea into the esophagus and cause air in the belly. If they have recurrent aspiration, maybe it's a chronic trach patient. This trach has been there a long time and it may be rubbing against the trachea and causes that hole so that it develops a fistula, and they slowly, when they eat, they're gonna, every once in a while, it's gonna go down to the lungs. So they're aspirating and getting pneumonias. This requires surgery. And the last one is tracheoinnominate artery fistula. And we will go over pictures so that you have a visual with this. So what are some symptoms that you would see with an artery fistula? So hemoptysis, dyspnea, and cyanosis. So can laryngeal lesions, stenosis, or vocal cord paralysis happen with a tracheostomy? No, because trachs do not pass through the larynx. So an endotracheal tube, most of that damage is going to come from the cuff site most often. With a trach, damage is most common at the stoma, but it can happen at the cuff or the tip. So endotracheal tube is most common at the cuff, and trach injury and side effects are most common at the stoma. And the stoma is where the trach goes in through the skin. So once they have that tracheotomy, which is the original hole that they cut to place the trach, once that heals, then it becomes a stoma. Now we have some pictures to help you kind of tie it together to get a visual of what I'm talking about. So in this picture, you have granulomas. And with this one, you have your tracheoesophageal fistula. Next we have, this is tracheomalacia. So you can see in that first picture in A, these are normal rings and normal patent airway. With malacia, you can see they're softened rings and it causes the airway to collapse. And then this last one is tracheal stenosis. So you can see that scarring of the airway, and then the narrow airway because of that. So some signs that you can look for on the ventilator, and you need to know this. So signs on the ventilator is you're looking at the graphics and you're going to look at the flow volume loop. So you can see it on the graphics on the vent, and then you can also see it if the patient does a PFT. If your patient has had a trach and they're a chronic patient and they've had it for months and months and months, and they leave the LTAC, or for whatever reason, they're decannulated and they don't need the trach anymore. And then they start to do PFTs because they feel short of breath or they feel like something's not right. On the flow volume loop with tracheal malacia, you'll have variable flow patterns, but it'll show obstruction. With stenosis, it'll be fixed. So it'll be like a round ball and then flat on both sides. So some symptoms that they will have would be difficulty clearing secretions, dyspnea, and stridor. And this can happen acutely, or it may happen over several months. So here I have some pictures to help demonstrate what I'm talking about with the tracheoinnominate artery fistula. So it's very rare. It only happens in 0.1 to 1% of patients, but it's only going to happen with patients who have their trach placed in the OR. It's less likely to happen with patients who have percutaneous trachs. It is fatal if not treated immediately. And of those who have this, only 25% of them will survive. So here you can see the trach from the front where it is placed. And so you have the aorta here, and then you have the innominate artery, which comes right off the aorta. So it's so close to the aorta that the end of the trach could end up rubbing against the trachea, and then it can rub through that artery, causing a fistula. When it first happens, you can see the tip of the trach here may hold it enough, once that little teeny tiny hole, to clot it to prevent that blood from coming out. But remember, the arterial system is a very high pressure system and it's coming off the aortic arch. So once that fistula starts to get bigger, it's going to cause a massive amount of blood and it needs to be treated right away and straight to the OR. A pulsating trach before the hemorrhage starts is one of the only signs. So if you're doing trach care and you notice it's pulsating, hyperinflation of the cuff can temporarily help. So that cuff will be inflated more to hold pressure until you can get out and emergently call someone to call the doc if he's not right in the ICU or close by, because this patient needs to go to the OR right away. Okay, some ways to help prevent airway trauma. Sedation's the first one. So this is going to help with trauma and decannulation, because if the patient isn't moving around, especially if they're on the ventilator and they may have ICU delirium, they may not fully understand what's going on, and they're hooked up to the vent. If they are moving around, they're not only damaging their stoma site, they are damaging their airway, but we're also afraid that the trach is going to come out, and that's called decannulation. So if they decannulate themselves, they're not going to put down that cuff, and that cuff can cause more damage coming out. And then we've lost our airway. We want to minimize the tube movement as much as we can. Trach care, suctioning, we want to be very careful with their airway so we can prevent causing further damage. Sometimes we can get a swivel adapter, or an extender piece so that it can help from give a little bit more space, but not too much from that vent circuit pulling on the trach itself. We want to make sure we have the correct airway size. If it's too small, it's going to cause damage. If it's too big, we're going to have to keep making that cuff bigger, and having more pressure on that cuff is not going to be good for their trachea. So cuff management, know this. This is very, very important. Cuff pressure needs to be 20 to 30 centimeters of water pressure. Cuff design can also help prevent further damage. So there are special trachs that have foam or water, and this reduces the pressure that's on the trachea if it's just an air-filled cuff. And this is another reason we want a trach collar instead of a T-piece, because it'll help prevent trauma and decannulation. So this is a picture of a Bavona foam cuff trach. It seals to the trachea by atmospheric pressure. So here you leave this little piece open, and it takes the pressure in the room and it will use that to seal the foam cuff here to the trachea. It's not common with patients until patients have tracheal damage, so long-term patients, because this is they're very, very expensive. Trachs are very expensive. So we're not going to use this on everybody because they are so expensive. So it's our patients that are chronically trached or have been and will be trached for a long time. When else might we use this? So we might use this for a hyperbaric chamber patient. Okay, trach care equipment. It's always important to know what equipment you're going to need for procedures so that you have everything you need when you go into the room. You can grab it and bring it with you. And also, so you're not in and out, in and out, in and out, it's going to save you time. So be able to list this and identify. So we'll go over pictures. I'll have pictures of all of these. So you're going to need sterile cotton tip applicators. Fancy word for Q-tip. But the key is sterile. Everything here is going to be sterile. Sterile 4x4-inch gauze pads. We're going to have trach ties or a trach holder, a sterile brush or cotton pipe cleaners, sterile gloves, sterile water, hydrogen peroxide, scissors, oxygen. We always have a spare trach, a syringe, and a cuff manometer. So remember, we want that pressure to stay between 20 to 30 centimeters of water pressure. And oxygen, I didn't mean to skip that one. Why does everything have to be sterile? So everything must be sterile because we are going in through their airway. Even though it's a trach, that is their airway. And we don't want to introduce any sort of bugs, debris, anything that could cause an infection or an obstruction or a pneumonia. We don't want to be the cause that they're sick. Trach care. So when I was a student, this is what I was most nervous about with my first rotation. I pulled my instructor aside. I was nervous about caring for the trach, of hurting them, of losing the airway. So if you feel intimidated by all of this, it's totally natural, and I promise you, you will be okay. We'll get through it. And trach care ended up being one of my favorite things to do. Top 3, extubation, ABGs, and trach care. It feels so good to help someone feel clean and fresh. You're removing their secretions so that they're breathing better. So soapbox moment. Trach care in most hospitals are typically BID. So once every shift. So if you're on day shift, when you see a patient with a trach, your first rounds, you're going to do trach care. If you're night shift, it's going to be the end of their day, it's the beginning of yours. So first shift or first rounds, you do trach care. And we're going to go over what trach care is. But if you go in, say it's your second round or your third round, and you see that they just have nasty secretions all over and they're dirty on their trach ties, or they're, oh, I'm forgetting the word, drain sponge, change it. It's no one's family wants to come in and just see that they're gross and yucky and nasty. I would be upset. And it doesn't feel good to the patient. Secretions can smell. And so it's just, they're a human being too. Okay, off my soapbox. So when you do trach care, you're going to want to start with suction. So I'm going to put this up here first because we haven't gone over suction yet, but you're going to want to start with suction. Because if you suction after, and if you have to move the trach around a little bit and you make them cough and it's clean and he gets more suction out or coughs more mucus out all over your clean trach ties, you're going to have to change them again, or you should change them again. So when you are doing trach care, you always want to make sure that they are pre-oxygenated. There's oxygen and there's an ambu bag. Always make sure that there is a trach the same size as the one they have in and one size smaller. Make sure that the obturator is in the room. If worse comes to worse, you could always pull an obturator out of one of the extra trachs, but it's better safe than sorry. Okay, so always make sure there's a self-inflating resuscitation bag in the room. I cannot stress this enough. So the first thing you're going to do, and I'm going to make a video of this. I have Trach Man, so we'll go over this. The first thing you're going to do is you're going to assemble and check the equipment. You're going to turn on the suction when you're ready to suction. You're going to explain the procedure to the patient, even if the patient is on a vent, even if you think the patient is sedated, even if the patient maybe they have a brain injury. You always tell the patient what you're going to do because you don't know what they can and cannot hear. And this can be a scary procedure if it's something that they have never done before. So you're going to suction the patient. So when you suction the patient, you're going to set the suction to negative 120 to negative 150 millimeters of mercury for adults. So we'll come up here. So suction, negative 120 to negative 150 for adults. And then negative 100 to negative 120 with children. And as you're reading and you're in other classes, it may fluctuate. So just know that depending on what you're reading, as long as you're within that ballpark, you're good. Okay, so you suction the patient, and then you're going to remove the inner cannula and either clean it or throw it away if it's disposable. Then you're going to clean and examine the stoma site, and you're going to check for redness, swelling. Are there any crusty mucus secretions? Is there any bleeding? Does it look like it's healing? Does it look infected? It's so important to know this and look at it, because then if something's going on, you can chart it. If you are on your first day of 3 days in a row and it looks okay, maybe just a little bit red, but it looks like it's healing, and then by day 2, day 3 that you're there, you're like, something's wrong. It would blanch and it looked okay. when I was cleaning it day 1, but day 3, now it's swollen and it's warm to the touch. Then you know, hey, this guy is becoming infected. So after you clean the stoma site, you're going to change your ties and your holder. So once those are all changed, you're going to replace the inner cannula or put a new one in. And then you're going to perform cuff care. You're going to make sure that the cuff is at 20 to 30 centimeters of mercury. Or sorry, centimeters of water pressure. And then you're going to reassess the patient. Now, while you're doing trach care and you're suctioning, you're going to want to move the monitor and make sure that they are still satting okay. If you suction the patient and you're down there and you're coming back up and he desats, put that oxygen on and just wait until he comes back up. You're going to want to hyperoxygenate the patient so that if you have to take away the trach collar and adjust the trach ties or clean the drain sponge and change it out, that they're already at 100% and it gives you a few minutes to change it and then put it back on. If the patient doesn't tolerate this and they're desatting, make sure you don't leave the patient until they are back up. You also want to leave the patient better than the way you found him. So if you come in the room and his drain sponge is covered in mucus and so is his hospital gown, you want to change his drain sponge, clean up his stoma site, make sure he's nice and clean. Let the nurse know. Let the nurse know, hey, I think he needs a new gown. He's covered in mucus. And most of the time they'll tell you, I noticed that and he's getting ready to have a bath or he's going to have a bath tonight, so I'm going to change it then. Wipe up the gown as much as you can. Also, don't leave trash all over the place. Make sure that you clean it behind you. That's a pet peeve of nurses and family members. Don't use the patient as a table. And when I start talking to you about in the video about how we do this, and so you can see it up close in the video, I will show you what I mean about using the patient as a table. Okay, troubleshooting emergencies, airway emergencies. So, know this. So tube obstruction is the first one. You can have a herniation of the cuff. So if the cuff is expanded and it goes over the end of the trach, it's going to cause that obstruction. So the first thing you want to try is to deflate the cuff. If this fails, then you can try to pass a suction catheter. If you pass that suction catheter and it doesn't go past the end of the trach, then you know that the cuff went over the tip. So that is why they're losing volumes or they are short of breath. You could have an obstruction because the end of the trach is against the tracheal wall. So that means you need to change the size of the trach. It may not be the patient's right anatomy. If they've had a trach for a while, it could be that they're developing tracheal malacia and they need a new size trach. You could have mucus plugging, like I was talking about earlier, and just big ball of mucus stuck in there. You could try taking out the inner cannula and either cleaning it or getting a new one. Sometimes you can put saline down the trach. We don't want to do that unless it's absolutely necessary, because then we're giving the lungs an extra place for breeding ground for bacteria and infection. After you put that saline down, you can try to pass another suction catheter and see if you can get that mucus plug out. But remember, disposable cannulas help prevent that mucus plugging. So cuff leaks is another airway problem that we might deal with. So it's primarily a problem with our patients who are on mechanical ventilation. Why would cuff leaks be a problem with these patients? Because it can cause decreased tidal volume. And remember, when I went over the trach tubes parts earlier, and we talked about that pilot balloon, it could be the cuff or the pilot balloon. So a little tip that I learned, if you want to figure out which one it is, if you can overinflate the cuff or inflate the cuff and then put a red cap. So it's this little, I'll draw it out. So it's this little cap. My drawing's terrible, I'm sorry. And it's for IVs. It's for the end of the IVs so they don't get dirty. And then say you have your balloon here. If you put that little red cap on top of it, and it's that one-way valve here that just got blown and it's slowly leaking out, and that red cap, and then you check on it your next rounds, and you see that the cuff pressure hasn't changed, you know it's a pilot balloon problem. And if the red cap fixes it, pass it on and report. Let the nurse know. If you see the doctor, ask him if he would like you to change the trach. But most of the time, if they're on mechanical ventilation and that works, as long as you're passing that on in report, it's okay to leave it like that. Now, there's been patients who that pilot balloon got cut off. If a nurse is shaving a patient after a bath and they accidentally nick it, or if it gets stuck pulled during x-ray, there's all sorts of scenarios that can happen. There's pilot balloon repair kits, and then that's why there should always be another extra trach in the room. Okay, so the next airway troubleshooting is accidental decannulation. It's gonna happen. It happens to everybody. Will have someone self-extubate, and everyone will have someone where they accidentally decannulate themselves. It can be the patient that does it. It can be a member of the team that does it. It happens. But the biggest thing is to stay calm. Because if you freak out, you're not going to be thinking right. And then you're going to cause the other team members to freak out. And if there's family, the family's going to freak out. The patient. With new trachs that are 4 to 5 days old, that hole and stoma site can close quickly. So it's important to stay calm and get the trach back in. Okay, this is where we're going to stop for today. So let me know if you have any questions. I want you to be comfortable with trachs before you get out there.